Hi guys, today we're going to talk about the genetics of heart disease and Alzheimer's. I also have a couple other cardiovascular disorders in this lecture that I want you just to have a brief touching on. I will tell you that there is not a chapter in your textbook that relates to these. I did my best to try to give you some information via a couple videos, and I will try to see if I can give you a couple other handouts to read if you're interested. There are just a few questions on the final that relate to this week with genetics of heart disease and Alzheimer's, because it does impact our health care quite a bit. We see a lot of people with both of these conditions. So printing out and having available to study these PowerPoint handouts will help you when studying for the final. So we know that they're multifactorial disorders. What that means is that there's an interplay between both our environment and the genes that we have that play a role in the disease development of both Alzheimer's and heart disease. But this is not very well understood. Research is continuing, and the goal of such research is to be able to gain a little bit more control over both, to help us better understand how we can change what we can within our environment to help with the genes that we have, so that we have less severity or later onset of these diseases. So we may have a genetic predisposition to these. Our genes may make us more at risk for the development. However, within the environment and our own genetic makeup, there are many factors that influence when we'll have onset of the disease, or the timing or the severity in which the genes will express themselves. So the first one we're going to talk about is familial hypercholestyramia. The basic defect with this disease is that is related to the low density lipoprotein receptors on our cells. So there's a defect in the LDL. And what happens then is we can have an elevated cholesterol level, we can have elevated triglycerides, or we could have both elevated cholesterol and triglycerides. You'll also see a mismatch in your LDLs to LDL ratio or counts. And because we have this greater propensity or elevated levels, we tend to develop atherosclerotic plaques in our coronary arteries at a maybe earlier age, at a more severe process quicker in somebody with this disorder. It is autosomal dominant, which means that we have to inherit it from at least one of our parents. And we know that the altered gene through research causes the condition in 1 in 2, 50% chance that we'll pass it on. So you only need one of these autosomal dominant genes to develop familial hypercholesteremia. But your parents could end up not passing it on to you. There are homozygotes within our population, and that means that these people have both copies. So they received one from their mom and one from their dad. And these are quite rare. They're about 1 in a million. But these children develop heart disease in childhood, and with more research that you're finding in the Stanford lecture, they have a greater rate of survival. But their heart disease and heart attacks and damage to their coronary arteries, research shows they don't live as long as the general population. And these people are going to have cholesterol levels in the 600 to 1200 range, and medication isn't going to help them. And then you can have the heterozygote. This is the person who only has one copy of the defect, and it only takes one copy to cause the problem. And these people are about 1 in 500. They're going to have a milder form of the disease, and their cholesterols range from 250 to 500 untreated. So there are about 400 different mutations that have been identified on the LDL receptor gene. The LDL receptor gene they have found is located on our 19th chromosome. The mutations in the gene are grouped into 5 classes, And patients with a family history of heart disease, especially at a young age, should be tested for this mutation. It's also recommended that people who have difficulty getting their cholesterols down despite medication, changes in diet and lifestyle, should also be tested for this mutation. So these are the different classifications, and what is the core problem with the defect. So this is a slide to kind of be aware of. So if you're a heterozygote, you will benefit from pharmacological therapy, but homozygotes generally have to have therapeutic apheresis, which is a way to remove the actual cholesterol from the blood itself. There are some new medications being developed out there to help the person who has the homozygote condition so that they don't require this. So some pharmacological ways we can help lower someone's cholesterol. So we want to reduce the cholesterol level. We want to divert the increased fraction of cholesterol to the bile acid synthesis. We want to help stimulate the receptor gene so that it can help lower that. And we want to make sure that the LDLs are taken up by the liver for excretion. So we can do that with statin medication. So the statins are going to decrease the amount of cholesterol you're actually going to make. So you're not going to make as much cholesterol. We can also use non-absorbable resins, and these are going to bind bile acids in the intestine and recirculation in the liver of the cholesterol, so that we're going to have more fecal excretion. Statin drugs tend to be more effective, especially when we use them with the bile acid synthesis resins, because they both remove the cholesterol and lower the cholesterol in two very different mechanisms. Lovastatin and Mevacor are the ones that seem to be the most tolerated for long-term use. However, people often don't like statins or the bile acid resin salts because they may have diarrhea. And especially with statins, you can have changes in liver enzymes, and some people get muscle aches and weaknesses. Another genetic area that they're finding is that some arrhythmias do have a genetic component. These genes that they're finding are related to some specific ion channels, and we call these channelopathies. They're finding within atrial fibrillation, or what's called long QT syndrome, that there is a genetic component to the development of these in some individuals. And you'll find long QT syndrome does run in families. So long QT syndrome, we know that there's a delay in repolarization in the cardiac cycle. The QTC measurement is elongated. What can we do for these people? We can either treat them with beta blockers, or we can give them a pacemaker, AICD, so that they don't develop the dysrhythmia. We can also have familial cardiomyopathies. There's familial hypertrophic cardiomyopathy. 1 in about 500 adults have this. It's autosomal dominant, and it causes an asymmetrical thickening of the heart muscle. The issue is related to ventricular filling, and there's a diastolic dysfunction, and there are often issues in the outflow tract. The diagnosis is generally made when a patient has left ventricular hypertrophy, and there's no other illness or cause that should result in left ventricular hypertrophy. You can have familial hypertension syndrome, or Gordon syndrome, or pseudoaldosteronism type 2. Rare inherited form of low renin hypertension associated with hyperkalemia and hyperchloremia, metabolic acidosis in patients who have this disorder also have these electrolyte imbalances. It's autosomal dominant. It is believed that 30% of people with hypertension do have a genetic link. Aside from these other things that we talked about that have specific diagnoses, that hypertension does run in families. Research is still trying to find the exact gene location, and if you'd like to read a journal article, I've left the link right there for you to find it. Now on to Alzheimer's disease. This affects about 1.4% of the people in developing countries. It results in about 100,000 deaths per year in the United States. The usual onset is between 70 and 90 years, although there's a monogenic form that presents earlier, sometimes as early as in their 30s. Signs and symptoms tend to be memory loss, disorientation of higher cognitive functions, and behavioral changes. What causes this is a degeneration of the neurons in our cerebral cortex, within the temporal parietal cortex, and within our hippocampus. A lot of tongue-tying words. So what is our pathological abnormality? Is that we have the deposition in the brain of two particular fibrillary proteins, a beta-amyloid peptide and a tau protein. There are different genes that encode for these proteins, and when you have these proteins, you develop these neurofibrillary tangles, and that's what contributes to the development of Alzheimer's. They are learning that there are other genes related to other proteins in the development of Alzheimer's, but nothing, no real specific thing has been put out there yet. You can have early onset Alzheimer's, and this occurs ages 30 to 60. This is about 5% of the population, and this, in most cases, this is inherited. This is what we would call familial Alzheimer's disease. There's a single gene mutation on these chromosomes, and the mutations cause the abnormal proteins. If you have the mutation on chromosome 21, 14, or 1, you can see what abnormal protein is developed in your brain. And these mutations play a role in the breakdown of APP. This breakdown is part of the process that generates those harmful plaques that are the hallmark of the disease. So this is also autosomal dominant. So you could get you have about a 50-50 chance of inheriting it if one of your parents carried the genetic mutation. And then we have late onset Alzheimer's. This is when it occurs after the age of 60. How it develops and the causes of it are not fully understood. There's a belief that it's both genetics and our environment, and there is some role our lifestyle plays in the development of Alzheimer's. The single gene mutation, like what is seen in early onset, is not responsible for late onset. They haven't really found any specific genetic abnormalities, but they do believe that there's a genetic risk factors that can be linked to the development. We believe that there's an increased risk related to the alpha-lipoprotein E gene, which is found on chromosome 18, and it carries instructions for making proteins. And these proteins help carry cholesterol and fats in the bloodstream. And there are these 3 APO genes. So if your defect is in the APO2, if your Alzheimer's disease is going to occur with this allele, it will develop later than it would with someone who has the defect in APO4. They believe APO3 is the most common to play a role in the disease, but it doesn't know whether it causes a decrease or increasing if you have it, the risk of development. About 25% to 30% of the population that has Alzheimer's, they see the defect in the APOE4. And all people who develop Alzheimer's are more likely to have a APO4 allele abnormality than those people who don't develop the disease. And looking at so some pharmacological therapy that we can have with Alzheimer's is we can use cholinergic drugs or parasympathomimetic agents, and they're going to help decrease the symptoms in the early stages. Some may be Aricept, and that's the end. I'm going to go back one. Aricept, some of the side effects might include headache, insomnia, and they increase the acetylcholine levels. And that's the end.